Good morning.
Good morning.
There we go. There we go. Good morning, all, and welcome to another CME meeting. Thank you all for being here for a prompt start, 8 o'clock start. I appreciate your timeliness. We have a very exciting topic to present to you today with a dynamic speaker. But before we get started, let's just quickly start with a word of prayer. Father God in heaven, we come before you this morning, thanking you for allowing us to see this another day. We thank you for allowing us to gather and assemble here as medical practitioners in the Bahamas. You have truly given us a mandate, and we thank you for entrusting the lives of so many patients in our hands. Guide us. We pray that you would open our minds to receive the knowledge that will be shared with us today, that it will truly make an impact on the patients that we serve. We thank you, oh God. This I pray in Jesus' name. Amen. Okay, so let's jump right into it and let's get started. Human immunodeficiency virus, HIV, has been described as a major global public health issue, having claimed more than 40 million lives to date. As of the end of 2022, it was estimated that approximately 39 million individuals are living with HIV. In the Bahamas, we have not been exempt from this epidemic. According to the UN AIDS report, at the end of 2018, there were 5,970 individuals living with HIV in the Bahamas. Although we have had our challenges, we have made some significant advancement in HIV prevention, testing, and treatment. It has been recently highlighted that newly reported HIV diagnoses have decreased by 63% between 2012 and 2022. There have been an increase in the number of individuals accessing medication, a decrease in reported AIDS-related deaths between 2012 and 2021, and no vertical transmission from mother to baby in 2022 in mothers who were on medication. Today, we will have a closer look at HIV testing, prevention, and treatment in the Bahamas. We are pleased to have with us today Dr. Nikkiah Forbes, consultant, internal medicine, and infectious disease specialist. I am certain that we are all well acquainted with who she is, but in the event that there is just that one someone who is not, I will give you a brief rundown. Dr. Nikkiah Forbes is the director of the HIV, AIDS, TB, STI, Infectious Diseases Program at the Ministry of Health and Wellness. She also serves as an infectious disease consultant at the Princess Margaret Hospital and Doctors Hospital. She currently is fully registered with the Bahamas Medical Council and the Medical Council of Jamaica. Dr. Forbes graduated medical school from the University of the West Indies with honors in surgery and was the first recipient of the School of Clinical Medicine and Research Cecil Bethel Award as the top graduate in her class in 2002. During her postgraduate specialty training in internal medicine, she was appointed the chief resident in medicine at the University Hospital of the West Indies, Kingston, Jamaica. After residency, Dr. Forbes completed a fellowship in infectious diseases at the University of the West Indies Faculty of Medical Sciences, Kingston, Jamaica, in conjunction with the University of South Carolina School of Medicine. Dr. Forbes has made and continues to make substantial contribution in the leadership, teaching, and management of infectious diseases. She was named a fellow by the Infectious Disease Society of America, which is that nation's leading infectious diseases professional society. She's a fellow of the American College of Physicians and a member of the Society for Healthcare Epidemiology of America and the HIV Medical Association. She serves as an advisor on the Ministry of Health Wellness COVID-19 Task Force and is the chairperson of numerous, and I do mean numerous, boards and committees. She is a faculty at the University of the West Indies School of Clinical Medicine and Research for just over 10 years now and has been appointed as a clinical tutor in 2018. Of note, Dr. Forbes has been described by the Prime Minister as one of the best and brightest in our nation when thanking her for her contributions and commitment to the Bahamas. Dr. Forbes focuses on serving with a sense of gratitude. As she frequently says, God has equipped me to offer skills that are people-centered and quality-driven. So with that very extensive bio, I want you to welcome this morning Dr. Nikkiah Forbes, presenting today on HIV testing, prevention, and treatment in the Bahamas.
Good morning, everyone. Thank you, Dr. Wallace-Bain. Thanks for that very, very kind introduction and wishing everyone season's greetings. Now, my video on my laptop is not working, so I also have my cell phone on, so I hope you're hearing me okay without too much feedback. And here are my slides. Let's try and make this a little bigger. We seeing everything okay, please?
Yes, we are. We're seeing you and wonderful. We're hearing.
Okay, well, thanks for inviting me to join you and talk about HIV and AIDS in the Bahamas, especially in this pivotal month of December, which World AIDS Day is celebrated on. World AIDS Day is on December 1st, and that really is a day where we commemorate the lives of those that we have lost to AIDS. We stand in solidarity with those persons who are living with HIV and AIDS, and we share the facts on HIV and AIDS and how we can end AIDS. So thank you so much for asking me to do the CME around World AIDS Day. So today I'm going to talk about where we are as it relates to the HIV epidemic. Thank you, Dr. Wallace-Bain. You talked a lot about the global epidemiology of HIV. And we're going to talk about where we are in the Bahamas in our fight to end AIDS and how far we've come. We're going to talk about HIV prevention, but I really want to highlight one particular aspect of HIV prevention, and that's the HIV prevention pill called PrEP, HIV PrEP. And we're going to talk about HIV treatment in the Bahamas and what is our gold standard of care now for HIV. And another thing I'm going to talk about under HIV prevention is HIV testing advancements, especially HIV self-testing. And then I will leave time for any questions anyone may have. So globally, there are 36.9 million people living with HIV at the end of 2022. We still had 1.3 million new HIV infections in that year. And despite our advancements, there were still 630,000 deaths due to AIDS that year. And as you can see, not everybody was accessing antiretroviral therapy. The estimate for those accessing antiretroviral therapy was 29.8 million. And so you can see that there's still a large treatment gap. There's millions of people. There are at least at least just about 7 million people globally that do not have access to antiretroviral therapy. In the Caribbean has the second highest prevalence of HIV in the world. There were 330,000 adults and children living with HIV. The adult prevalence is 1.2%. And in the year 2022, there were an estimated 16,000 new HIV infections. People are still dying of HIV. There were 5,600 people who died of AIDS in the Caribbean in 2022. And we also have a treatment gap. There were 220,000 people on antiretroviral therapy. In the Bahamas, we have made some advancements. At the end of 2022, a nice round number is just about 4,000 people were estimated to be living with HIV or AIDS. And the concentration of HIV in the Bahamas, there's a generalized and concentrated epidemic. About 1% of the general population has HIV, but there are some population groups that have a higher HIV prevalence. This is based on a sero-surveillance sentinel study that we did at the Ministry of Health in 2016. And in that year, there was a possibility that 16 to 19% of men who have sex with men presented with HIV during that study period. Now, as we look at the epidemic curve of HIV, we've been following it since the first case in the early 1980s. You can see here there's a line graph in the bottom corner of the slide. You can see that in 1993, that was the peak of newly diagnosed HIV cases in the Bahamas, and there has been a steady decline since then. And so we had an all-time low of 112 new HIV cases diagnosed in 2021. 68% of those cases were male and 32% of those cases were female. And so we have had a precipitous decline. In the past 10 years, there's been a 63% decrease in new HIV infections. But we have more to go, because even one case is too many. And so when we think about how to end AIDS, and we definitely are at a place where we can end AIDS, we have to start with HIV prevention. And that is pivotal to the end of AIDS. And so I have a mentor, Professor Figueroa, and he always highlights that HIV prevention has to be a combination of approaches. And when we look at prevention, there are various modalities that we have to address if we want to optimize and reduce the chance of persons having HIV. So prior to HIV exposure, we have to address the social determinants of health. Where you are, where you're born, your situation, can you have access to health care? Do you have access to health education? Are you stricken by poverty? That will impact choices. We have to think about rights-focused behavior and making care accessible to everyone and treating people with dignity and respect, and providing care that's focused toward persons that are most affected by HIV. There's HIV testing. We're going to talk more about that. Once upon a time ago, that was provider initiated. It took a doctor or a healthcare worker to say, this patient is presenting with chronic diarrhea and weight loss. Perhaps I should do an HIV test. Then people could come in and say, I would like to have an HIV test, or couples could do an HIV test, but we've advanced HIV testing over the years. We've made it so much faster. It can be at points of care. And we also have HIV self-testing, which I'm going to talk more about in the next few slides. Sexually transmitted infections should be screened for and treated because they certainly increase the risk of HIV acquisition. Male medical circumcision. There are studies that suggest that males that are circumcised have a reduced acquisition of HIV for various reasons, including the surface area under the foreskin. There's HIV pre-exposure prophylaxis, and there are also studies looking into preventative vaccines. At the point of transmission, male and female condoms that are used appropriately and correctly significantly reduce the chance of HIV. Please ask your patients to use it through the entire sex act before penetration and with water-based lubricants. Then we think about the prevention of mother-to-child transmission of HIV. We've had no cases for at least 5 years among mothers who have appropriately had antenatal care and have had effective antiretroviral therapy if they're HIV positive. There are needle exchange programs in places where injection drug use is high. Let's not forget HIV post-exposure prophylaxis, and that can be occupational after a needle stick, but it also is non-occupational. And those are cases where the condom broke during sex, you're not aware of the HIV status of your partner, no condom was used, or the condom was used part of the time, or uncertainty about whether a condom was used, for example. That is medication that needs to be started within 72 hours after the exposure. There's studies into microbicides, and after infection, HIV treatment is also prevention, as well as treatment for opportunistic infections, basic care and prevention, education and rights-focused behavior, and there are others like vaccines and functional cure. So as my mentor says, well, we need a combination approach because none of these approaches is 100% efficacious and something that everybody will do, basically. I'm going to talk a bit about HIV testing now, and I particularly want to highlight HIV self-testing. So HIV self-testing is a quick, convenient, and confidential HIV testing option. It's a way to reach more people, especially those in hard-to-reach places, people that are undiagnosed. And it's a way to bring services closer to people where they live. And it can facilitate early diagnosis before persons become sick. And so oral HIV self-testing has been around in the United States, at least since the year 2016, in the form of the OraQuick HIV self-test. This test relies on oral fluids. It is easy to use. It is packaged with instructions. The client can buy these tests at various points of care, and they swab the mucosa, the gingiva, over the gums, and then place the swab into a liquid-based reagent, and the results will come back as reactive or positive in about 15 minutes. And it looks a lot like you could think about a COVID test where there may be 2 lines if the test is positive, or a pregnancy test where there are 2 lines where the test is positive. If it is negative, the control line only will be visible in the window. And so the test allows people to test themselves for HIV in a private, convenient, and confidential setting, whether this is in their homes. It can be done at points of care. At points of care, it can be assisted or it may be unassisted. And importantly, if the test is positive, so here are examples of people using the OraQuick. You can see the swab of the gums there. There are also finger stick options, but we are not recommending the finger stick option. People preferred the oral option when we piloted this, when we did our study and piloted this. You will see that if the test is positive, this is going to require confirmation. We call this a test as triage. And it certainly is not a final HIV diagnosis. The patient will need to go into a lab, or they will need to go into their doctor's office and get linked to care so that that test can be confirmed. And once the test is confirmed as positive, we would want them to enter care, get linked to care, see their physician, do the other investigations that are necessary before starting HIV treatment. The test, we launched this officially in the Bahamas. It did require an in-country verification and validation exercise, which we completed. We did find that the oral test performed 100% concordantly with the national HIV treatment algorithm. And so we're pleased to announce that this is now available in HIV testing guidelines throughout the Bahamas, and it can be obtained by patients in the private sector at a very low price. So I hope that you will be seeing patients who may be presenting to you after having done an HIV self-test. Get for more information, for example, if it is an HIV positive diagnosis, they will be coming into care and looking to continue their treatment. They may also be preventing for HIV prevention modalities, and there is information and links to all of these services in the test kit. Okay, so that being said, let's talk about HIV prevention. So suppose your patient comes to you saying, I would like some more information on HIV prevention. There are persons who possibly are coming in seeking HIV prevention medications, the HIV PrEP pill. So let's talk a bit about that. So what is pre-exposure prophylaxis, or PrEP? Oral PrEP is an HIV prevention strategy in which a high-risk HIV negative individual takes antiretroviral medication regularly to prevent HIV infection. And at this time, tenofovir emtricitabine, or Truvada, is the agent that is approved for HIV PrEP in the Bahamas. Certainly there are other drugs that are being looked at now. There are added benefits that provide some protection against HSV and hepatitis B. So what is it? It's a reverse transcriptase inhibitor. It is a single dose. It's co-formulated into one single pill. It has a very good safety record. We've been using it for HIV treatment in combination with other medicines for a number of years. It works very well. It's very well tolerated. It has a long half-life of about 48 hours, and there's high penetration in vaginal and rectal tissues. And so here are some studies that look at the use of daily PrEP for HIV prevention. So here are the names of the studies. There was the IPREX trial, Partners PrEP, TDF2, and the Bangkok TDF study. And here are the populations that were studied. So in IPREX, it was men who have sex with men and transgender women. You can see that there were a number of countries in which patients were recruited. The drug was tenofovir emtricitabine, a large number of participants, just about 2,500. And what did they find? They found that the chance of reducing HIV, or how well it worked, it reduced HIV acquisition by 92%, especially if patients were adherent. In the IPREX study. Then in Partners PrEP, we found here that this was serodiscordant heterosexual couples. It had a 90% effectiveness if the persons were adherent. TDF2, that was a little lower, 76%, and 70% in the Bangkok TDF study. But notably, if persons did not adhere to PrEP, it was not very effective at all. And you can see that the decrease in HIV incidence overall was lower in those persons who were not adherent. In TDF, it was 67%. For TDF, emtricitabine, it was 75%. And so the take-home message here is that PrEP works if the client is adherent. And so here's a meta-analysis of all of those studies. When the 18 studies of PrEP were reviewed, that collated to about 20,000 participants. There were a number of persons included: serodiscordant couples, men who have sex with men, transgender women, women and heterosexual men, and IV drug users. And we can see that compared to placebo, that there was definitely a reduction in the risk of HIV acquisition, and that trials with PrEP use of more than 70%, there was the highest effectiveness there, and low PrEP use did not demonstrate a protective effect. And so in this meta-analysis, it was found that PrEP was very, very effective, that it was about 96 to 98% effective if it was used appropriately. It was also found to be very, very safe. The majority of persons had no side effects from PrEP. About 90% of users reported no side effects. About 10% of people had some short-term mild side effects, and those included gastrointestinal symptoms like diarrhea, little dyspepsia, nausea, decreased appetite, abdominal cramping or flatulence, a change in their kidney function. And remember, the drug tenofovir can reduce bone mineral density. And so there was a slight decrease in bone mineral density in people taking PrEP. It was also safe to use in pregnancy and breastfeeding. And so the WHO has recommended HIV PrEP as an additional HIV prevention modality for people who are at substantial risk of HIV. And it should be offered as an additional HIV prevention choice in a comprehensive package of services as a part of combination prevention. And so I really want to highlight PrEP because all providers should be able to prescribe PrEP. It can't be that PrEP is only prescribed in infectious diseases clinics or in STI clinics. Those are certainly places that PrEP can be offered. We could think that in the HIV clinic, if persons are coming in and they're in discordant relationships, they could bring their partner in or refer their negative partner for PrEP. And certainly if people have an STI, they would benefit from HIV PrEP. But we have to offer PrEP when we are doing our annual visits with patients every year. You might see your patient only once a year. They're coming in just to check their labs, to make sure they don't have high cholesterol, to screen for diabetes, kidney disease, and so on. Or please offer a sexual history, because sexual health is also a part of health, and talk to them about their risks for HIV acquisition and acquisition of STIs. And we have to get comfortable doing that. And for those that are at risk, they can be offered PrEP when you talk about how to keep themselves safe and talk about STI and HIV prevention. So who should be considered for PrEP? So the CDC recommends PrEP for persons who are at risk for HIV and STIs, and let's try to unpack that a little bit. It could be heterosexual men and women with multiple partners or not also always using a condom. However, some people might have one partner, but their partner is high risk. Their partner may have multiple partners, and a condom may not always be used. They may not know about that, but they could come in with an STI. In that case, of course, HIV could also have been transmitted. It is recommended for sexually active men who have sex with men who are not always using condoms and have multiple partners, for example. Serodiscordant couples, one partner is HIV positive, the other partner is HIV negative, especially if the HIV positive partner does not have an undetectable viral load. It is also recommended for injection drug users and sex workers and clients of sex workers, for example. But I want you to think a little further and a little more broadly about PrEP. Sometimes clients come in and tell you they would like to have PrEP. And when you take the history, it may not be clear to you, but usually if people present and say, I'm interested in PrEP, they may have a reason. They may not always use condoms, for example. If they've had an STI within the last 6 months to a year, then think about people who cannot negotiate when sex happens. If somebody is, for example, the victim of gender-based violence, they would benefit from PrEP. That is, if someone cannot always control whether a condom will be used, they will benefit from PrEP. If condoms are not always consistently being used, it could be a relationship where there's a power imbalance. PrEP is something that is controlled by the client. So in order for the client to start PrEP, they have to be HIV negative. And we talked about who may benefit. Now, there are contraindications for PrEP. If they're HIV positive, they cannot be on PrEP. They would need to be on a fully active HIV regimen. If they have kidney disease, if they have a creatinine clearance that's less than 60 mils per minute, then Truvada or tenofovir-based PrEP may be contraindicated. If the person has, say, for example, they came in for post-exposure prophylaxis, non-occupational post-exposure prophylaxis because the condom broke or it wasn't used, then what you would do in that case, you would offer them post-exposure prophylaxis for the recommended 28 days, and then you could transition them to PrEP. But this is where the third bullet point comes in. If they have features of an acute HIV infection or acute seroconversion, then you have to be very, very careful. because they may be in the window period. Their HIV test may be negative, but they may have high-level viremia, and you shouldn't start those persons on PrEP. What you should do is evaluate them to see if they have acute HIV infection, or of course, if they're allergic to any of the medications in PrEP. So your client comes into you and you've done their sexual history, or you've seen them for an STI, or they come in asking about PrEP, or they're in a discordant relationship, and you say, okay, I think this patient may benefit from PrEP. Well, what's the next thing that you do? You have to do a baseline evaluation for that patient. So once you've determined that they're eligible and they have an ongoing risk for HIV, you have to determine that they are going to take the medication, because as we saw in all of those studies, PrEP only works if you take it as recommended. And so they have to be committed to taking those medications daily and follow up. There are some exceptions. I'm going to come down to that at the end of this part of the PrEP training. You have to screen them for HIV, and they may require further assessments. If you think that they're an acute seroconversion, you would have to do a viral load to make sure that they are not in the window period. You have to screen for hepatitis B, because remember, we can use tenofovir for hepatitis B treatment. You have to have a baseline renal function before starting the tenofovir-based medication, an STI screen at baseline. This is going to include syphilis screening. You could do an RPR or a VDRL. You have to screen for chlamydia and gonorrhea. A urinalysis, NETs will be fine for that. A baseline pregnancy test for women, and counseling. And so once you have all of these results back, once you have back the renal profile, you're pending the other results, but at a minimum, you have to have the renal profile. You can now start your patient on PrEP, which in the Bahamas is tenofovir emtricitabine, 1 tablet once a day. And you will want to be following up with your patient. You can dispense medication, but no more than 90 days at a time, and emphasize adherence. So I did say that daily PrEP is what is recommended. Now, there are some other ways to give PrEP. There's something called PrEP 211 or PrEP on demand. This was studied in men who have sex with men and can also be very effective. But this is for persons that are not having sex very often. If they are having sex, say, less than twice a week, say once a week, maybe once every month, there is a way to give PrEP on demand. And that has only been studied in MSM couples at this time. And what it is that the PrEP has to be taken within an hour before sex, basically. And there's 2 tablets as the loading dose. Every day that the client is sexually active, they take one of the tenofovir emtricitabine pills, and then they are going to continue to take it for at least a day after the sex is stopped. It's called PrEP 211. This has been effective. It has not been studied in heterosexual couples. There are also persons who are also doing off-label, like vacation PrEP. If persons are going on vacation, for example, they may be loading the PrEP. So it's good for providers to know about this. However, most of the experience has been with daily PrEP. There are injectables that are also in use. And so here's a list of the investigations that are done prior to starting PrEP. I talked about the HIV test, the serum creatinine, hepatitis screening. We talked about STI screening and counseling. I have to emphasize that because you have to think about how you're going to counsel your patient for other prevention modalities, because PrEP is not going to prevent STIs. And you do need to discuss condoms and lubricants, because ideally PrEP is designed to be used with condoms and lubricants. It's not a magic bullet. And certainly there are cases where breakthrough cases of HIV happen even though the client is on PrEP. And it's not very common, but I can give you some examples of when that happens. So persons who have a high amount of exposure to HIV and very high risk behavior can still get HIV on PrEP. There was a patient who did get HIV on PrEP, and it seemed that he was having sexual relations at least 3 times a day with multiple different partners, and he was exposed to a strain of HIV that was resistant to tenofovir emtricitabine. And that is very, very possible that if clients are exposed to resistant strains of HIV, they can still get HIV on PrEP. Again, if the client is not using it, they can definitely get HIV on PrEP if they're not using it properly. Those are a few of the cases where breakthrough HIV infections can happen. So you do have to counsel your patient very carefully. You're going to want to follow your patient up. So when you follow your patient up, remember, you're only going to be able to dispense 90 days of the PrEP medication. After that time, they should come back to you. You're going to be talking about how the PrEP went. Were they adherent to it? Were they using other preventative measures? They have to be screened for STIs, and you have to reevaluate the need for PrEP. Sometimes clients will tell you, no, doc, I don't need it anymore because I'm not sexually active at this time, or I broke up with the partner, or I think I'll just stick to condoms. I don't feel like taking the medication every day. So you really have to reevaluate it. And every 3 months, there's some lab testing that needs to be done. They have to be having an HIV test. You want to make sure that they did not acquire HIV on PrEP. They have to be screened for sexually transmitted infections. Their renal function has to be reviewed at least every 3 to 6 months, and pregnancy testing for women who may become pregnant. You also want to review side effects. Like I said, it's quite tolerable. And again, counsel, and risk reduction behaviors. And so how long can they be on PrEP? They can be on PrEP as long as the risk of HIV infection persists. And what about the serodiscordant couples? For the partner who's HIV infected, if they have a suppressed viral load, that may suffice to prevent HIV transmission between the partners. However, there are cases where clients who are in serodiscordant relationships will continue PrEP even if their partner has a suppressed viral load. They may have other partners. They may have concerns that the HIV-infected partner is not taking their antiretroviral therapy all the time, because having a suppressed viral load or an undetectable viral load, that's at a particular time, right? That's not necessarily something that's going to continue. It requires commitment to medication. So suppose you're seeing your client and they're on PrEP, but now their repeat HIV test is positive. Then what do? You have to evaluate them, and then you're going to have to start them on medication. Right? We talked about how that can happen: transmitted drug resistance or acquired drug resistance. And so how do you manage the patient? You will have to confirm that they're HIV positive, and you will have to transition them to a fully suppressive HIV regimen. And so you could, for example, continue the tenofovir emtricitabine and add dolutegravir, and see how they do on that if you had no reason to suspect that they were exposed to a resistant strain, for example. So there are other ways to prevent HIV, which we've talked about, but HIV treatment is also prevention. And so I really wish that we'd known this in the 80s and the 1990s, because we probably wouldn't have had so much stigma and discrimination about HIV, and particularly people who have an increased risk for it. And so we know HIV treatment is also prevention. And so there is a campaign that you've probably seen on TV. It's U equals U. And that stands for undetectable equals untransmittable. And so there's some science behind this. So in a nutshell, for someone who is living with HIV, if their HIV viral load is undetectable, they are not able to transmit HIV, whether that's sexually, even without condoms, mother to baby, IV drug use. And here's the science behind it. There was a landmark NIH-funded study called HPTN 052. And this is a clinical trial that showed that there was no linked HIV transmission occurring among HIV serodifferent heterosexual couples when the partner living with HIV had a suppressed viral load, had a durably suppressed viral load. And there were other studies that supported this. And those studies are partner and opposites attract. And these studies were confirmed and extended to male-male couples. And so in HPTN 052 in 50,000 sex acts, there was no HIV transmission at all once the HIV positive partner had a undetectable viral load. So that's a very, very good thing. So undetectable is very good for clients. It means that hopefully their immune system will not be having immune system decline from CD4 cells being destroyed, for example, that they will not be getting opportunistic infections, and HIV is not undetectable. At this time, this is active. So that being said, I want to talk now about HIV treatment, especially HIV treatment in the Bahamas, and what is our gold standard best medication for the treatment of HIV at this time, mostly as an overarching treatment. Of course, there will be some exceptions. So when you're seeing your patient, when do you start antiretroviral therapy? You should start as soon as your patient is diagnosed, presuming they're ready to start medications. So the START trial showed us that if persons start as early as possible while their immune system is preserved, that potent antiretroviral therapy improves and preserves their immune function in most patients, especially if we can get virologic suppression, regardless of the baseline CD4 count. So it's indicated for everyone, regardless of CD4 count or symptoms. And the earlier started, the better. It's better for the patient's immune response, and it's better for clinical outcomes. It reduces AIDS and non-AIDS associated morbidity and mortality. Remember, there's significant HIV-associated inflammation and complications, even if there's no immune system decline, and there's a reduction in HIV transmission. And you should use the best possible antiretroviral therapy combination you have that's potent, durable, and tolerable. So potent, it's really powerful. It gets viral suppression fast. It's durable. It's not going to be at risk of getting resistant strains, and that the patient is not going to have side effects and easy to take. Now, I have to say this because even in this day and time when we're rounding on our public hospital service and other places, sometimes patients will say, well, I saw a provider, they said I wasn't feeling sick at this time, and they didn't opt to start me. So I have to reiterate that you want to start when your patient is diagnosed for the most part, okay? Once they're ready to take it, you've confirmed their HIV status, you've done their necessary screening labs, please start as early as possible. The ideal time is when you are talking to and counseling that patient and talking about the HIV diagnosis and how there's treatment when you have them in your care. We call that linkage to care. Whenever they've seen a physician and they have their bloods taken like viral loads, that's called linkage to care. That's the opportune time. If you are seeing the patient in the hospital and the patient is discharged, sometimes they don't come back for one reason or another. They may be not knowledgeable about the health system. They feel afraid about the HIV diagnosis. They are in denial. So there are studies that suggest that if the patient starts medication early, they're more likely to stay on medication. So there are things that need to be done to support them starting medication when you're seeing them. Let's talk about what some of those things are. So we talked about these are the WHO recommendations of when to start. It should be in all people living with HIV, regardless of clinical stage and CD4 count, rapidly, as fast as possible. So this is called rapid ART initiation. So when I say start as soon as possible, now when I say that, there's still some preliminary things that you have to do. And so that's why the WHO says that rapid initiation is defined as starting antiretroviral therapy within 7 days. Okay, now in places that have a lot of support, so you can get your renals back in an hour, then maybe you could start earlier than that. So let's talk about what you need to have. All right, so in order to start your patient, you would need to counsel them. You would have to assess that they're ready to start antiretroviral therapy. You would need to do some baseline tests. You would need to do a serum creatinine and a metabolic panel. You also would want to do a urinalysis. That should be normal because tenofovir is it's the backbone of many of these regimens. You should do STI screening. You should do a baseline chest x-ray. You might want to screen for TB, latent TB or TB exposure. You could do that with a MAN2. Of course, that's not going to come back right away. You will do a complete blood count. You could do baseline toxo titers, for example, because we know that toxoplasmosis is a reactivation problem. You could also do a cryptococcal antigen, but at minimum, you have to do a metabolic profile that includes renal studies and STI studies and a CBC. So you should take those off, and a urinalysis, in order to go ahead and start your patient on therapy. The other thing is you have to confirm that the HIV test is positive. Sometimes clients might come in and they may just have a preliminary positive. I've seen it from some private labs and it hasn't been confirmed yet. So you definitely want to have the confirmatory HIV test. Now, you can go ahead and start your patient on therapy. You're going to do a side effects review in about 2 weeks to make sure that everything is staying fine, that they're tolerating the HIV medication. Now, when I said that we're going to start everyone as rapidly as possible, there are some exceptions. And here are the exceptions. Persons who have certain opportunistic infections, like cryptococcal meningitis, you should not start those clients. They're going to develop a life-threatening complication called immune reconstitution inflammatory syndrome, or IRIS. They're going to do very badly. The mortality of that is high. If they have PCP, especially if they have PCP, you really cannot start them right away because of that risk of IRIS. And there are certain other conditions, for example, neurological problems, if they have histoplasmosis, in some cases, TB, it depends on their immune status. It depends on what their CD4 count is. Sometimes, based on their CD4 count, we may defer starting antiretroviral therapy for 2 weeks, 4 weeks, or 8 weeks, depending on their CD4 count. And so I will say to you that when you have an HIV patient who is symptomatic or has advanced disease, if their CD4 count is low, I would say even, we used to say below 200, if it's below 300, 350, if you suspect that they have an opportunistic infection, if they're pregnant, if they have clinical symptoms, whether it's wasting, they have skin rash, oral candidiasis, if they have any symptoms, you should refer them to the ID clinic so that we can assess them for opportunistic infections and decide when the timing of antiretroviral therapy is. So suppose your patient is fine. So ideally you have a patient who has HIV, their immune system is normal, their CD4 count is preserved. You should have taken off a CD4 viral load at baseline when you're evaluating them, by the way. They have no symptoms and they're relatively well, then please do go ahead and consider starting them for antiretroviral therapy. And so what drug would you use? Years ago, here in this picture, that hand that's full of medications, that is what HIV medicine used to look like. People used to have to take that, something like that, 3 times a day. But now HIV therapy can be 1 pill once a day. And that is our best regimens. It's 1 pill once a day. And at this point, I always say, if you had to take medication, if you've ever had to take medication, say you had a UTI, say you had a skin infection and you had to do a course, you know that sometimes it's hard to finish that course. And so if you had to take medication every day, what would you want? You would want the medication to be 1 pill once a day. You would love it to not have side effects or not cause toxicity like kidney disease, liver disease. You would want it to work really, really well. You wouldn't want it to just stop working. If you had a UTI, you wouldn't want to start medication for 2 days and then your UTI bacteria get resistant and now you have to start all over again. You wouldn't want it to interact with any foods or drugs. It should be affordable. Wouldn't it be great if it was low cost? And it should work really well. And so that's the holy grail of medication. And so we have something like that now. And it's 1 pill once a day. But I will just tell you that antiretroviral therapy, there's a lot of options. And so There are at least more than 30 medications for the treatment of HIV now. We have the backbone drugs, the NRTIs, we have abacavir, emtricitabine, lamivudine. We don't want to use stavudine anymore. We don't have it. It has too many side effects. We still have zidovudine. Then we have the NNRTIs, for example, nevirapine, which we do not want to use anymore. It has too many side effects, and efavirenz that also has side effects. It causes drowsiness, for example. Then we have the protease inhibitors. Well, these drugs are very, very potent. So you've heard of some like Kaletra, which is lopinavir, ritonavir, boosted. Then there's atazanavir, darunavir. That's a second generation one. That's more potent. And nalfinavir, that's been gone for a long time now. But these drugs, for the most part, or Kaletra, for example, is 2 tablets twice a day. Atazanavir has to be boosted. Sometimes that comes all in 1 tablet. That can be once a day. But the main problem with these drugs is that they cause metabolic problems like high cholesterol and high glucose. There are fusion inhibitors. We have the INSTIs. So the drug I'm going to tell you about is called dolutegravir or Tivicay. There are other INSTIs, raltegravir. It's rather expensive. And there are injectable formulations of cabotegravir now. And of course, some of these drugs come in fixed dose combinations. At this time, our best medication is an INSTI regimen, and dolutegravir, by and large, is our most available and recommended drug. So dolutegravir is an integrase strand transfer inhibitor, and it has many of the qualities of optimized preferred drugs, and it is our currently preferred regimen. This has to be given with a backbone. And it is available in a combination pill that includes tenofovir, lamivudine, and dolutegravir, a simple 1 pill once a day. And so that has been our recommended ARV since 2017. It's also the WHO recommended first-line HIV medication. So in case residents also always tell me, okay, you know, all these drugs, it's very, very confusing. All you have to do is write a Cryptiga, 1 pill once a day, and we have multi-month dispensing. We want to give at least 3 months if we have the supplies for that. Okay, a Cryptiga is tenofovir, lamivudine, 300 milligrams of each, and dolutegravir, 50 milligrams. It's once a day. It can be used in adults and children and infants. That would be the best drug. It's very well tolerated. It has very few side effects. One of the major side effects of dolutegravir is it causes weight gain. And so you want to ask your patient to stick to a healthy diet. It doesn't seem to cause weight gain in persons who exercise and watch their diet carefully, but it can cause weight gain in people who tend to intake excess calories. Of course, there are exceptions, and so there are other first-line regimens you can consider in a patient that you may not want to give dolutegravir to. Suppose they're allergic, you could. We also have another INSTI regimen, bictegravir, but that is something that needs to have formulary sign-off on. And there are the other medicines. Atripla is still a 1 pill once a day dose, and that also works quite well. And then there are other medications like protease-based regimens. But if your patient is failing the regimen, then we would want you to refer those patients. So what about second line? So if your patient was not on a dolutegravir regimen, or if you have a patient not on a dolutegravir regimen right now and they're not doing well, you could certainly switch them to the dolutegravir regimen. It does work very well, and then you would want to review their viral load to see if their viral load is indeed becoming undetectable. But if you have a patient that is failing, then please refer the patient to infectious diseases clinic. And so here are some of the patients that should be seen in the ID clinic, and these are people who are HIV positive with symptomatic and/or advanced disease. They have either clinical failure, they're losing weight, they have an opportunistic infection, they're developing significant oral candida while they are adherent on their medication, immunological failure. If their CD4 count is declining to less than 200 consistently, you should refer that patient. There are some persons whose who are immune system depleted. So even years later, even though they're doing very well, their CD4 cells may not rise above 200. And that's based on the severity of their HIV disease at the time of diagnosis. So you can look out for that. Persons who are having virologic failure, a consistently elevated viral load, despite adherence to therapy, you should refer those patients. If they're having side effects, moderate to severe side effects on antiretroviral therapy, if they're having drug interactions, if they're co-infected with TB or hepatitis B or C, children and adolescents, pregnant women, or they're failing second or third line therapy, please refer those patients. And you have to monitor your client. So sometimes clients don't get monitored, they just get started on medication and that's it. But just like how we follow up on people with hypertension and we make sure that they have reached their target blood pressure, that we're screening them for comorbidities like hyperlipidemia, heart disease, retinal disease, renal disease, we have to follow up the HIV patient. And so a viral load is the gold standard test for making sure that the client is doing well. So the viral load should be done on a fairly regular basis for those patients that are asymptomatic, they have good immune systems, you've started them on HIV medication. Now you're going to want to repeat their viral load. It can be anywhere between 12 to 24 weeks after starting therapy. I've seen it work faster. Sometimes in pregnant women, we do their viral loads more frequently. I've seen the dolutegravir regimen work faster. Okay, so once they've achieved a sustained undetectable viral load, they've had an undetectable viral load for at least a year, then you can actually do the viral load maybe every 6 months. Sometimes it's done annually in some centers. However, every 6 months allows, if the patient misses an appointment, they don't follow up until later on, you will know that their viral load is suppressed. You should also follow their CD4 count to ensure that their immune system is fine. You may order these tests more frequently if you have other reasons. For example, if you think that your patient is failing, of course, you might order these tests more frequently. And so this is my last slide. I think we are almost at the end. And so I will tell you about where we are in our treatment cascade in the Bahamas. And so we want to end HIV and AIDS. We know we can do it now based on science. And this is because of all the advancements and all of the work like doctors like you over the years and all the scientific advancements and those physicians and scientists that have committed their life to research. So we understand with an undetectable viral load, HIV cannot be transmitted. We've discussed that from persons living with HIV to their partners, to their children. And we know that this this only happens after treatment. We also have to consider prevention because remember, HIV prevention is a spectrum. We started with prevention this morning. And so Professor Gardner years ago asked a question. He said, well, if we've come such a long way with HIV medication, you can take one pill once a day. Why do we still have new cases of HIV? We had 112 cases in the Bahamas, for example. There were still 1.2 million infections last year alone. And it's because there are gaps basically in this spectrum, in the HIV spectrum from prevention all the way down to treatment. And so let's look at where we are in the Bahamas. So in the Bahamas, here was the estimated number of people living with HIV in 2022. I said it was about 4,000, right? Not everybody knows their status. If you don't know that you have HIV, then you're not really going to change your lifestyle or anything much. There are studies that show that if people know their HIV status, they will do things to reduce transmission and maybe come into care. And so not everybody knew their status. Only 93% of people knew their status who had HIV in the Bahamas in 2022. Of those persons who know their status, not everybody is on treatment for lots of reasons. It could be because they are in denial, they don't like the services that they're getting, they don't want to be on medication, side effects of medication. You start medication and you stop, and then not everyone gets viral suppression for a lot of reasons. It could be the persons are not taking it all the time. It's resistant strains, for example. And so here are our numbers with where we are in the fight against HIV. Well, we know that if we can get everybody, as many people as possible, undetectable, then, and as many persons diagnosed and as many persons on treatment, that's going to significantly reduce the chance of new HIV infections. This has to happen over time. We have a 10-year period to get this done by 2030. All of this initiative started in 2015. In the first 5 years, 2015 to 2020, the goal was to get 90% of people knowing their HIV status, people with HIV knowing their status. 90% of those on treatment and 90% of them virally suppressed. That would give us 10 years to get to 95, 95, 95. And if that could happen globally, all the UN countries in solidarity, then there would be so little HIV that it would be something that could almost be eliminated. So we have diagnosed 93% of persons, 82% of them are on medications, and 81% are virally suppressed. And so we are making some progress, but we have a ways to go. So we have more people to diagnose, more people to get on treatment, and viral suppression, very, very, very important. We've got to make sure that we document it and keep our patients virally suppressed for them and for others. But that is my last slide. I think I'm out of time now. And so in summary, HIV treatment includes multiple classes of medications. Currently, we've had advancements to the new INSTI regimens. The regimens are now improved and optimized with new preferred medicines offered. And our preferred regimen the abbreviation is also TLD. You can write that out as a cryptogram. We know that HIV treatment is prevention and undetectable equals untransmittable. PrEP is an additional prevention option. And I hope this helps a bit to just give you an update, especially on the best regimen for treating your asymptomatic HIV patient and how you can go ahead and prescribe your patient HIV PrEP as a part of the HIV combination prevention approach. Thank you very much for inviting me to present with you in this month where we celebrate or commemorate World AIDS Day. And that's the end of my presentation. I'll turn it back over to you, Dr. Bain.
Thank you so much, Dr. Forbes. That was an excellent presentation. It was very comprehensive. You hit on some very important points for us to be aware of in our clinical practice. You definitely improved our knowledge. And with that knowledge, I hope we are better able to fill that gap and together work towards meeting that goal by 2030. So we appreciate you so much for being willing to come and give us this talk. We have some comments and questions in the chat very quickly. So our first question by Dr. Strawn: how do we get Aura Quick kits? Who sells or gives away? Dr. Forbes?
Sorry, I wanted to turn my video back on. I don't know if that helps.
Oh, you're muted, Dr. Forbes. We're unable to hear you.
Okay, can you hear me now?
Yes, we can.
Okay, thanks. That's a really great question. And so the Aura Quick test, it's the only approved test for oral HIV self-testing in the Bahamas. It's the only one. And that's a number of reasons. There are a number of reasons for that. It's the only FDA approved test. It's the only WHO approved test at the time when we did the validation exercise. Now, this test is going to be available in various settings. It's going to be free at the HIV Center and our testing outreaches. It is probably already being used in physicians' offices and in insurance places. For example, you know, when you go for insurance and they do an HIV test and you can get an oral test in a physician's office, that's the test kit that's being used. It's being used already. So when it is a self-test, though, clients have to be able to use it themselves. So it will be available at points of sale, whether that's a supermarket, the pharmacy, It could be at clinics, for example, and that's going to be distributed through the local distributor who has the rights to distribute the OraQuick, and that's Ports International. Okay, but the whole idea of the oral self-test is to put the responsibility and the ability to do HIV testing in the client's own hands. You know what I mean? Because there are already ways that people can do HIV testing. So in brief, they could go to a lab, they could go to a doctor's office, for example. You could even go to a lab anonymously. However, there are a number of clients that will not do any of those things. So remember when I showed you the treatment cascade with 93% of people knowing their diagnosis, there's 7% of people who don't know their diagnosis. Some are reachable, but some are not reachable. So I'll give you a little story I had. So in some of my work I do as programming for HIV, we try to bring HIV testing to non-traditional settings. Like we could go to a fashion show, for example. We could be invited through our partners who work with at-risk communities to put on testing. And I went to one of our partners. I was invited one day, and the feedback was, we can only do these tests in places where people are going to feel safe and comfortable. They're not going to come into a doctor's office or clinic. And so if you had it in your office, that's great too, but it's how do you make this test more accessible? Could you pick this up off the shelf, like a pregnancy test or a COVID test, for example, right? So that's kind of the unreached population that we are trying to reach by making this test available as a self-test.
Okay, thank you, Dr. Forbes, for that answer. Quick housekeeping, please remember to fill out your CME feedback link. We would greatly appreciate that. And we have other comments. Great presentation. Valerina Taylor, Dr. Black, thank you for an excellent presentation. I am so pleased to hear that we can get rid of HIV. Completely agree with that, Dr. Black. She furthered her comments by saying, and thank you for sharing the strategies. We have a question from Valerina Taylor. Is it advised for an undetectable mother to breastfeed her baby?
Yeah, that's another good question. So we don't recommend that in the Bahamas, but it's not wrong, right? So this is what it comes down to. If the mother has an undetectable viral load, then HIV will not be able to be transmitted to her baby, even by breastfeeding. So it is allowed in some places. The WHO will say yes, the the mother living with HIV can breastfeed. But we remember that guidelines are always just general guidelines. There were things that I said today that did not, are you hearing me okay? There were things that I said that were not applicable to all populations. I think someone's microphone is unmuted. And so here is what that general guideline looks like. Of the 7 billion people in the world, there are some places where there is not a safe water supply, and that babies die from gastrointestinal disease and dysentery because there's no safe water supply. That the safest food supply for newborns and infants is breast milk. So you have to kind of balance it, right? Like everything we do, the risk versus the benefit. So in places like that, if you say that a mom can't breastfeed, well, then you're increasing the chance that a baby gets diarrheal disease, dehydration, and dies. And so, yes, it's true scientifically that if her viral load, the mom's viral load is undetectable, it would be safe for her to breastfeed. Now, what is our context in the Bahamas? We have a safe water supply. We have free formula for infants that are born to mothers who have HIV. And we know that there could be gaps where HIV transmission might still happen even though the mother had an undetectable viral load. So if she was not adherent to medication, that might increase the risk of transmission of HIV to the baby, and it is a potential opportunity for mother to baby HIV transmission. And so we do not recommend that breastfeeding happen. We recommend that the baby is formula fed, and of course the mother will continue HIV medication. There's some other things. I'm not a pediatrician, but we've seen some things like mixing foods and inflammation in the baby's tummy that can lead to the baby getting HIV, which is very, very sad, because I'll tell you, there were 26, something like that. Okay, mother to child transmission before we had effective antiretroviral therapy, it was 26%. Right now we're down to no babies being born with HIV because of effective medication. But sometimes we still do see some things, right? Like babies presenting late because, say, the mother chewed the food or gave the baby food, or something happened after the baby was born, even though the baby seemed to be born HIV negative. So no, we don't recommend breastfeeding.
Oh, sorry about that. We have another question. Good morning. Thank you for a lovely presentation. Do we need training still to do proper counseling?
So there are some persons that are in attendance that have been doctors for a long number of years. And at that time, HIV counseling was a big, long thing. It was like hours, at least an hour, where you had to sit down and find out risk. And, it was really, really a very, very long exercise. But with the change in how HIV testing is offered, that these new testing modalities do not lend for that long, hour-long, 45-minute process where HIV counseling is done before HIV testing. Another example of that is point of care or universal HIV testing at points of care, right? Where in a busy emergency room, for example, you can't do that 45-minute long testing. And so the self-test, also, you won't actually be interfacing with the client at the time they buy their self-test. And so we have modified the counseling so that the information could be available in other ways. In the self-test, there are links to videos where counseling is provided and information is provided. And there are also links to prevention. How do you get into care, for example? And so counseling has also changed and been modified to fit the testing scenario. Now, that long testing and counseling, we still have that. It has to be applied to the patient. So just like everything is patient-centered, it's based on the individual patient. There are times when you do need that longer HIV prevention and testing and counseling before the testing and afterward. If you're interested in learning more about that, you could contact the HIV Center. We have experts at that. So if you're interested in expanding, we also have lay counselors and testers and persons from affected communities. If you're interested in learning more about that, you could call the HIV Center. You also, if you're a part of communities, you have a church group, you have a civil society organization, you volunteer, that you can call the HIV Center and set up an outreach and testing or informative talk, education, any of that could be arranged.
Okay, thank you. More comments. Thank you for a very informative presentation. Dr. Hannah, excellent presentation as usual, Dr. Forbes. How is pre-testing counseling addressed in the setting of HIV self-testing, and has there been any negative psychological fallout of persons discovering their positive status through this means?
Yeah, that's also, a very, very good question, because self-testing has been around for a while, but you're not going to be there with the patient. That's the whole idea, that they have the test in their own hands. They take responsibility of their health in their own hands. So what we do provide is a necessary support around the self-test. There is a QR code on the box, which takes persons to a resource page. that has the facts on HIV. What is HIV? What if this test is preliminarily positive? That it reiterates that it needs to be repeated. It has HIV prevention links and resources. It talks about HIV treatment, for example. And it's the kit. Part of what we had to do was we had to include that information on our local resources in the kit. And so that's how it's handled. So, over the years, we've had focus groups on people and their experience with the kit. And well, there hasn't been any self-harm associated with the kit, but some people do give feedback. There are stories about how they used the test and how they felt after getting the results, whether they were positive results or negative results, and what they did and how they got linkages to care. There one has to be careful as well, because the kit is designed for adults or persons above a certain age to do the test on their own. It's not for coercion or anything like that to do the test. And you know what? We can't control every single scenario, but what we do have to do is we have the responsibility to provide the necessary support around the test. And so the question you asked has been asked before in various groups, and there are some persons who think maybe HIV self-testing shouldn't be offered because maybe people might harm themselves. However, we do have to give people every opportunity to take responsibility for their own health. And an HIV self-test is not the only form of self-test around. There are self-tests to diagnose UTIs, STIs, COVID, pregnancy, for example. There are a number of self-tests, sinus infections when you're ovulating. And so we do have to allow innovative technologies so that we can provide the best possible care.
Thank you for that answer, Dr. Forbes. I think at this point, it's important to put in a plug for the importance of primary care in this role, because we want every Bahamian to be connected with a primary care physician, that physician who you are completely comfortable with, the physician who you trust. And if you were to do an oral test at home, that you know that you have that medical person who you can reach out to and go through whatever emotion it is that came along with the test that you would have done privately, whether it was positive or negative. So I think it's very important. Again, I put out there, if you know of a patient who is not connected with a family physician, please get them connected. It's so beneficial. So we have more questions and comments. We're going to try to get through these really quickly because time is getting away from us. Dr. Parkinson, what is the status of the HIV vaccine?
Yeah, that's a great question. I wish it was here, but it's still in trials. They've had some setbacks. It's being worked on diligently, but there is just no vaccine that is effective at this time. Our best shot right now is getting persons undetectable for most people.
Thank you, Dr. Cooper. Excellent presentation. Multi-drug combinations cause significant GI side effects. I'm seeing this frequently with HIV patients. How are you managing this in your practice? Are there meds that are better tolerated than others with respect to GI upset?
Thanks, Dr. Cooper. Yes, this happens with some clients, but really, I'm really happy this new regimen, this INSTI regimen, the tenofovir, lamivudine, dolutegravir, is really well tolerated. I think it's actually the most tolerated regimen I've seen to date. There are very, very few people who have side effects on that regimen. So I do realize you have a patient who's struggling. In that case, we have to give symptomatic relief. We can sometimes try and switch them to other regimens that they tolerate better, but it's not, it's some of those patients, they are going to have some side effects. So, it's a risk versus a benefit thing. So symptomatic management. Thanks for the question.
Okay, Rogers, great presentation. As always, Dr. Forbes, totally agree that persons requesting testing prep with vague responses, we need to be thinking gender-based and domestic violence. Dr.
Yeah,
Roka
I agree.
Davis.
I think Dr. Rogers just hit the nail on the head. She sees a lot of persons at risk too. And so when we read these PrEP guidelines, a lot of them seem very, very concrete, but PrEP is actually, there are subtleties for who would benefit from PrEP. And so, gender-based violence. And if someone is in a relationship where they're suffering from gender-based violence, and, violence comes in a lot of ways. It's not always physical. It could be emotional, it could be manipulation, it could be economic. But here's what it boils down to. If the client cannot control sex, in those cases, when sex happens, if there's a condom, they feel that they're at risk, they're definitely clients for PrEP. It doesn't always have to be gender-based violence. It could be there are subtleties, or there are persons who they say they are in a committed relationship, but then they come to you and they have cervicitis and chlamydia is positive. You understand? So it's challenging. Offer those patients PrEP. And then this also comes down to the social determinants of health.
Absolutely. Dr. Roka Davis, thank you so much for a very informative presentation, an excellent reminder to spend a little bit more time and even more specific when it comes to the sexual history during annual physicals.
Yeah, for sure. So sometimes providers themselves are not comfortable talking about sex, but just you have to include it in your annual. You have to say, how's your sex life? Are you sexually active? Anything has changed? Any new partners? You get more comfortable more times you do it. And definitely, if there are risks, talk about HIV and STI prevention.
Agreed. Tanya's iPhone, please remember to change your names to the name as it should appear on your BMC. Excellent presentation, Dr. Forbes. For patients with intellectual disability that may not have good support as an outpatient, is there DOTS available for healthcare providers to give the medication daily?
This is HIV medication, I take it, right? So in some cases, we do that. You could do it by cell phone now, by video call. But there are other ways. So we have a full adherence support team.
The wonders of technology.
Mm-hmm.
Dr. Han Burrows, thank you so much, Dr. Forbes, for an informative presentation. As always, are there any concerns that there will be any delays with persons presenting to care after self-testing?
Well, yes, that's possible, because we will not have that client with us. If they buy that at a point of care, we won't have them with us. And so, but we have an obligation. So we have a responsibility to provide that information so that they can be linked to care and know how they can get into care. I could tell you some of the things that people said in focus groups. And so one particular lady, she did do an HIV test. This is not here, this is in Trinidad. Because someone told her, someone she was dating, maybe was losing weight, and she had some suspicion. She did the kit at home in her bathroom. It was preliminarily positive. She was, she did have some emotions around it. She did go and link herself into a clinic. But we can't control every scenario, especially with point of care tests. So it is possible to actually go online and say, I do have the self-test kit. Here's what my result was. There are other opportunities. If we are giving them away, we could follow up with the client. If our lay providers and groups that work with most at-risk populations, they can also do that. But in truth and in fact, if this is picked up off the shelf, you will not know about that client. So we do just have to provide the necessary support. But we also do know that people who are aware of their HIV status, that there's a study that suggests that they automatically do HIV prevention behavior to reduce spreading it to other people. There's a study about that. So that will be a step in the right direction for us getting to the end of HIV.
Thank you. And we have one final question from Dr. Lockhart. Excellent presentation, Dr. Forbes. I'm sorry if I missed it, but do we have the sensitivity and specificity data for oral cell test? And do we have a timeline for the potential availability of the kit for screening in hospital?
Okay, yes, great question. So earlier in the presentation, I said that there had to be a national validation exercise for this test kit to be available and a testing policy around this. So even though OraQuick has been available for years in the United States, the WHO says you have to validate it in country based on your national algorithm. So that was done. And you have to have a testing policy that includes it. That has also been done. So in the validation exercise, the OraQuick test performed 100% concordant with our national algorithm. It's supposed to be at least 96% sensitive based on the FDA information. Now, remember, this is a test that is a test as triage. Someone cannot do this test and say that they definitely have HIV. They could have a false positive or a false negative. There are things that are going to impact that test, the way it's done, how it's stored. It has to be read within 15 minutes, not after that. If you've seen any of those COVID tests, you let it sit for a long time, you start to wonder if there's a double line. So the instructions have to be followed, and the patient must have a repeat HIV test in keeping with the algorithm. Now, the kit should be available, I would say, by January 2024, if not sooner, at points of care through the distributor.
Okay, thank you. So we have no further questions or comments, but I think it is safe to say that everyone thoroughly enjoyed this presentation. And thank you once again, Dr. Forbes, for taking the time to increase our knowledge and to help us level up in our medical knowledge regarding HIV.
Well, thank you again.
So thank you to all. Oh, sorry. Thank you to all of you who stayed on the call. Many of you stayed for us to continue, even though we went a little bit over time. But when you're getting good information, time just seems to run away from you, and that's okay. Just want to give you a few reminders. Again, please ensure to fill out the CME. It's posted in the link, the feedback. Want to remind you that we have come to the end of the road for this year of CME presentations. This is the last CME presentation for this year, and we will resume the end of January 2024. Looking forward to seeing all of you so we can continue our education journey throughout the year and to boost our level in knowledge so that we can effectively help the patients that we serve. Additionally, I just want to thank all of you for your support thus far. I want to wish you all a very Merry Christmas and a happy, prosperous, healthy New Year. So, see you guys next year.
Snow.